Thank you so much for having me here today. My name is Amie Shao. I am a principal with Mass Design Group, and I'm joining you actually from Kigali, Rwanda. Back in March, on March 27th, actually, we received a call from a couple of doctors at Mount Sinai Hospital, which was at the epicenter of the New York City pandemic. And at that point, COVID was still a very new thing to all of us. Healthcare systems were scrambling to set up policies and procedures and find PPE and mobilize staff and prepare for what we knew was coming, a surge. But it was already very apparent that healthcare workers were in an extremely vulnerable role. At that point in late March, more than 62,000 healthcare workers across the US had already contracted COVID, and at least 290 had already died. And what you just mentioned, staff, systems, and supply chains were being addressed, but space, this was very early on, and space wasn't yet being looked at. So we wanted to see whether there were ways that the physical environment of COVID care units could be tweaked or changed to lower infection risk to healthcare workers. The team that we set up was a group of clinicians and designers with really diverse experience. We had doctors from Mount Sinai Hospital, a world-renowned medical center at the epicenter of the US pandemic, architects and design researchers from my firm, Mass Design Group, which is a nonprofit. We've spent the last 12 years designing healthcare facilities all over the world with a particular emphasis on infection control, as well as doctors and researchers from Ariadne Labs, Joint Health System Innovation Center, founded by Dr. Atul Gawande. So beyond leveraging the vast experience and perspective of our clinical partners, we built upon our own experience designing against epidemics, combined with the work that we've been doing around novel research connecting space and outcomes. So, Mass was actually founded 10 years ago in response to an infectious disease, extremely drug-resistant tuberculosis, which was being spread in crowded hospital wards and waiting areas in limited resource settings. So our first project was the design of a district hospital in rural Rwanda for Partners in Health and the Ministry of Health that was fundamentally designed around air. The massing of the hospital, rather than do a big multi-story hospital, we broke it up and had smaller volumes that sought to eliminate double-loaded corridors entirely, and we were able to leverage the temperate climate of Rwanda to do so. And inside, we inverted the layout of the wards so that we could maximize natural and cross ventilation, and then also we're able to integrate high-volume, low-speed fans, which aren't shown here, as well as ultraviolet germicidal irradiation on the top plenum of the buildings. In Haiti, we designed a hospital specifically for multi-drug resistant patients for our partner Geskio, and here around a central courtyard, we wrapped isolation rooms that were laid out to reduce the exposure of medical and cleaning staff to potentially contaminated air. We'd also built a cholera treatment center in Haiti, which is a waterborne disease which broke out there after the 2010 earthquake, as many of you I'm sure are aware of. And we built an underground wastewater treatment system to clean and filter the water and ultimately stop the cycle of reinfection that was coming up from treatment facilities. And the design of the space itself sought to bring light and air and greenery into an otherwise very miserable and undignifying disease. And then in Liberia, after the Ebola outbreak, we worked with the government to build a 250-bed hospital, which was designed not only around air and water, but around rebuilding the public's trust in the health system. So beyond those design projects, we'd also been developing spatial research methods, which were trying to look at how we can connect space and outcomes. We'd work with Ariadne Labs with funding from the Robert Wood Johnson Foundation on a year-long project aimed at looking at whether the layout of labor and delivery units was actually affecting the rate of unnecessary C-sections. And, as you know, most evidence-based studies in healthcare look at the scale of the room or kind of elements that are very definable, but we were interested in the system forces that are affecting how clinicians make care decisions. So we were looking at the maternity unit as a whole. We visited and collected data on case studies across the country, and we engaged clinicians to help us visualize the care processes that were going on. And that ultimately allowed us to generate testable hypotheses that linked healthcare space design measurements to C-section rates. And we were able to publish the results of our work in some peer-reviewed journals, which we were really excited about. So that was all the background, that was the foundation. And so in early March, when COVID was emerging, we'd begun developing some general resources for spatial thinking related to COVID infection control. So when we got that call from Mount Sinai, we were able to start very quickly. And what we recognized was that there were many hospitals that were implementing spatial redesigns on the fly without much guidance to prepare for the COVID-19 surge. So what we wanted to do was capture quick interventions that were working and share lessons to assist other facilities on how they could be more informed in moving forward. So what we did together was document how spaces were being adapted by developing quick and nimble approaches to research and collaboration. So the question that we had to grapple with was, what does evidence and research look like when we're moving so quickly and without much guidance? We couldn't apply the methods that we normally would, which would be clinician shadowing, holding workshops, running simulations ourselves to see how care processes work. In those early months of COVID, as Nicholas Kristof reported in the New York Times, it had been easier to be embedded in Army units in Iraq or Afghanistan than to embed with doctors fighting COVID at that point. So our research study lasted 3 weeks, and it was a rapid response spatial research method that employed a lot of different types of approaches. So over Zoom, the doctors led us on virtual walkthroughs of active COVID care units, and we had to really carefully outline what we wanted to see and have them do practice run-throughs on non-active floors ahead of time in order to optimize their time on the COVID floors and keep them safe and also not impede the care processes. And then using GoPros strapped to their chest, they also captured time-lapse footage of COVID ICUs, which allowed us to go in and later look closer into the photos of what was going on. We ran a series of interviews with facilities teams and clinical operations teams, people who were putting these changes into place. And then we worked with clinicians to have them also annotate floor plans to visualize how the spaces were being used. Let me just go back to this for a second. So I think from a personal standpoint, it was a really incredible and surreal experience. As I mentioned, I'm located in Rwanda. So due to the time difference, physically, I was sitting on nighttime calls in my kitchen, slapping mosquitoes away, and virtually I was touring busy intensive care units in New York City. I think this type of collaboration across geographies, across time zones, across disciplines was really incredible and felt very urgent and of the moment. And what we saw on those phone calls was some really unprecedented spatial change. And we saw a lot of critical care taking place beyond the normal confines of the patient room. So at that point in mid-March, Mount Sinai had already begun really radically transforming its care delivery system. They changed their main atrium, their main lobby here, into a 100-bed step-down unit. And then they built a temporary 68-bed tent facility across the street from them in Central Park. And then within their existing ICUs and med-surg units, they transformed 260 existing patient rooms, normal patient rooms, into negative pressure isolation rooms. So for this example, in this ICU, the openings had previously been open, and so they constructed walls and doors across those fronts of the bays. They brought in large HEPA filtration units and set them up to directly exhaust outside of custom fit wood panels that were installed in the windows. And the change at which these things took place was really radical. Here's a before and after of just one floor of the hospital showing how 3 intensive care units were converted And the buildings themselves were literally intubated to expel contaminated air. I would pause for a moment to recognize the uniqueness of this floor plan, which was designed decades ago by I.M. Pei's firm. So it was an honor to be looking at such a historic piece of architecture. So what we quickly grabbed onto was that the in-between spaces were really critical. You know, a lot of attention was being paid to the patient rooms themselves, how to make them negative pressure. But all of these hallways were really where we wanted to address risk. In order to minimize clinician exposure in patient rooms while still allowing for that really high acuity care to happen, these double-loaded corridors suddenly became the do-everything space. They accommodated IV poles, as you see here. They accommodated patient monitors, PPE stations, waste receptacles, staff workstations, clinician rounding, and a lot of the care processes that had previously taken place in patient rooms were now happening in the corridors. Many of them, as you can see here, were already narrow, particularly in an urban environment with older infrastructure that was limited. But when crowded with all of this equipment, as well as teams working and making rounds, this didn't create the safest conditions for healthcare workers. And we recognized really quickly that enforcing proper infection control protocols in corridors and key thresholds like unit entrances was just as important as in the patient rooms. So in the end, we looked at 3 different COVID-19 units: an ICU, that was an adult one, adult medical unit, and then a pediatric unit. And we found that amidst the really heroic efforts to transform hospital-wide clinical processes and infrastructure, there were a lot of adaptations that varied between floors and between units. And between or within adult ICU units, it wasn't possible to integrate antechambers or changing areas due to the spatial constraints of the floor plan and the need to maintain direct visibility right into the patient rooms. In one unit, as you can see here in the upper right image, colored tape was used to try to delineate the threshold in front of patient rooms and demarcate contaminated zones. But specific areas for where you should don and where you should doff were not delineated, and the system wasn't super clear and it wasn't applied to other units. This was a kind of a test one. We did see a lot of innovative design hacks that were implemented by both the hospital and the clinicians, which were innovative, but also revealed some implementation gaps and confusing variability between units, like informational signage or the way that individual face masks for doctors were being stored, as you see in the brown bag system here. So what we learned from this initial study over 3 weeks was the notion that spatial literacy, which basically means like how one reads and perceives space, can be leveraged to keep people safer. So when we were engaging with the hospital clinical staff, we saw really big differences in personal perception of risk zones within care units. So one of the things that we did was ask clinicians to create what we called risk heat maps. We had them color code printed floor plans using red for the hot, in the clinical terminology, hot or risky areas, green for clean or safe areas, and orange for areas that were somewhere in between, areas with potential infection risk. And as you can see here, 3 different clinicians drew completely different maps and had completely different perceptions of what is essentially the same unit, reinforcing our observation that spatial literacy not only has, it has really direct implication on the interpretation of donning and doffing protocols and affects not only what level of PPE clinicians need to put on, but where they do it. So in the rush to expand bed and caregiving capacity, hospitals hadn't yet been able to have the time or the energy to develop the human-centered design cues to communicate key information and enforce adherence to protocols and create order and confidence. And because staff responding to surge conditions are often redeployed and assigned to work in unfamiliar environments with new team members. Like imagine yourself coming to a new space for the first time with people who are fully gowned up. You can't tell who they are. You don't know them. Visual aids and design nudges, even things as simple as paint or tape on the floor, can help to lower infection transmission by making invisible risks more visible and orienting people and creating spaces that instill confidence and collaboration. So we mentioned that this is a research project, and ultimately the lessons that we took away from those 3 weeks were that first, time is of the essence, and as designers, we need to be able to mobilize really quickly and collaborate deeply and leverage nimble research methods to respond in situations that are unpredictable and constrained and out of our control. And we also acknowledge that, perhaps more than ever, space has a really vital role to play. The physical environment shapes how people behave, how they interact, how they make decisions, and spatial literacy and design cues are key to indicating risk and standardizing behavior to keep people safe. So after collaborating with Mount Sinai, we published a report of our research, which is now on our website, and we went on to develop other COVID design resources, including design recommendations for, this one's for senior housing. We also did it for hotels. This one's for restaurants. We also did it for museums and schools and even prisons. And, now our team is working to put together a learning collaborative of multiple health systems. We want to look at a broad range of facility types and geographic contexts in different moments of the kind of wax and wane of the pandemic. We want to expand to look at a broader set of care delivery spaces, not just dedicated COVID care units. We want to look at a broader definition of safety beyond infection control, but also things like communication and morale and stress management, and for all healthcare workers, not just clinicians. And ultimately, we hope to develop clear spatial guidance that can be used globally to transform hospital units in the COVID-19 era. So I think just to conclude, NASA's motto or thesis since its beginning has always been that buildings are never neutral. They either help or they hurt. And as I think we all acknowledge, COVID brought to light a lot of cracks in our systems that were previously less visible. It revealed issues of equity, it revealed how interconnected and interdependent we all are, and it revealed that we need to be designing for health in the largest sense of the word. So I'd say that, on the plus side, it's also created a bigger awareness of the role of the built environment in keeping people safe. There's a lot more discussions in general media and among the public, no matter what community or field of work you're in, and people have an awareness of what spaces you feel comfortable in and the density of those spaces and a tacit understanding of airflow versus stagnancy. And so I hope that we can be optimistic that this will open up a greater appreciation and value for the role of design in all kinds of spaces. So thanks for letting us share today, and look forward to the presentations.
Thank you, Amie, and fantastic presentation. Very hard topic, and delivered on time, even from my perspective. There's a couple of questions. Saga, will you take them?
Yes. Thank you, Amie, for your presentation. I got a question here from one in the audience. He asked, he said first, this is a fascinating work, but did you have an opportunity to also follow the engineers, technicians, and facility managers during this period? Because you talk a lot about the clinicians.
Yeah, so we did. We didn't have the engineers and technicians. We didn't do the Zoom work with them in terms of the touring because they were not in the active COVID care units at that point, but we did a lot of interviews with them, and I think recognized that it's really important to bring together the viewpoints of all of those various types of folks that are playing different roles in kind of making all of the facets of the space and stuff and systems and I'm forgetting what. Anyways, come together. And And the clinical operations team and the facilities teams were working really closely together. So unpacking kind of how they did so well and how they could have done so better, I think will be really important in figuring out what are the best systems for teamwork and communication within hospitals, and how do they bring in collaborators to be able to do this better. And there are so many learnings that they had to share from, what were some of the early problems were, a lot of were on the procurement side of how they get all of those HEPA units and all of that stuff, and to what degree they are implementing changes that will be very permanent versus very temporary. Nobody knew at that point. So they did the best they could and mobilized really quickly. And I think capturing those lessons was really important as well. Thanks for the question.
Thank you for answering that question. Now we will go to the next speaker, Michael.
Yep, thank you very much, Amie.